So my name is Professor Michael. I'm a medical oncologist and also co-chair of the neuroendocrine tumour service at the Peter MacCallum Cancer Centre. And we're Australia's largest standalone cancer centre. And we're also a ENET Centre of Excellence. We have the largest NET practice in Australia. And I've been asked to have a chat about a few aspects. One is the trials that matter to me that possibly are practice changing. The next is, what are the gaps in the research, the current research, which can direct us to better therapy for patients? And the other is, what's the role of patients in trial design and in trial advocacy? So let's talk about the first aspect, the trials that matter and possibly are practice changing. It really comes down to a couple of aspects. One is looking at the increasing in the indications of peptide radioreceptor nuclide therapy, or PRRT. And we're seeing an increasing number of trials in this regard. And there's been we've had the COMPETE trial, which is a randomized trial of PRRT versus everolimus in patients with JEP-NETs, grade 1, grade 2, which is just finished recruitment. And we're very anxiously awaiting for that trial to read out. And it will be the first trial we're actually we're comparing PRRT either first or second line to a biological agent compared to higher dose somatostatin analog, which was what used in the NETA trial. So this is what I expect is probably a better design trial, much more realistic in the approach of patients with this disease. We also have the COMPOSE trial recruiting patients at the moment, and that's looking at the role of PRRT versus either everolimus or FOLFOX or CAPE-10 chemotherapy in well-differentiated aggressive grade 2 and grade 3 disease in patients with either gastrointestinal or pancreatic neuroendocrine tumours. And again, this looks at the role of PRRT in this patient group which have very aggressive disease, where normally they would be treated with systemic or chemotherapy. And it's based upon high-quality retrospective trial data showing PRRT has very good activity in these disease subsets. There's increasing work of looking at PRRT in patients with non-JEP-NET disease, including pulmonary NETs, pheochromocytomas, paragangliomas, etc. And again, it's based upon retrospective data and case series data showing that PRRT does have activity in this disease. So it'd be very nice to see prospective phase 2 trial data in this area. We're also looking at ways of optimizing the use of PRRT, and this includes basing the dose of PRRT on dosimetry by looking at, can we individualize the dosing of PRRT in patients rather than just giving a single dose, the same dose to all patients. More interestingly is combining PRRT with systemic agents to increase the effect of PRRT on the tumour cells. And there are current trials combining it with DNA damaging agents such as the PARP inhibitors, including olaparib. And we're also doing a trial to Peter MacCallum looking at another PARP inhibitor called teleroposib as well. We're also combining PRRT with the checkpoint inhibitors such as pembrolizumab and also nivolumab. We do know from the preclinical data that it does show that radiation therapy is immunogenic itself, and therefore hopefully we can optimize this interaction by using the immune checkpoint inhibitors. And there's also work combining capecitabine and temozolomide in combination with PRRT in patients with pancreatic neuroendocrine tumours. And we've seen the recent results of the control NETs trial emanating from Australia showing that in the pancreatic neuroendocrine tumours, the combination of capecitabine and temozolomide does result in improved response rates and also PFS rates in combination with PRRT. In terms of going away now from PRRT and looking at better systemic agents, we have seen the results presented in ESMO this year of the AXINET phase 3 trial in patients with neuroendocrine tumours outside of pancreatic NETs. And it does show that axitinib in combination with sandostatin LAR compared to sandostatin LAR plus placebo, it does show an improved progression-free survival, approximately 16 versus 9 months, and also better response rates. And we're also seeing trials combining cabozantinib, which is another multi-targeted tyrosine kinase inhibitor, in pancreatic nets. And we're also seeing now phase 3 trial data of surafatinib, which is a multi-targeted tyrosine kinase inhibitor, which in the Chinese phase 3 trials, both in pancreatic nets and non-pancreatic nets, showing very interesting efficacy, being tested within the Western population. And it's also being combined in one study with, again, an immune checkpoint inhibitor. And there are also trials combining the PARP inhibitors, the DNA damaging agents, with the capecitabine temozolomide bases as well. And more interestingly, we're seeing more and more trials now combining nivolumab with ipilimumab in patients with rare tumours, including neuroendocrine tumours. Over the last few years, we are seeing increasing activity of trials specifically rated to grade 3 neuroendocrine tumours or neuroendocrine carcinomas, which again, these are very aggressive subsets. We've had the recent results of ESMO 2022, the NIPNEC trial of nivolumab compared to ipilimumab nivolumab in patients with grade 3 neuroendocrine carcinomas. And this cohort of patients is mainly lung, but about 20% of patients are pancreatic. And it's again showing overall activity of nivolumab just as good as the combination. We're also seeing immunotherapy such as nivolumab being combined with platinum-based chemotherapy in grade 3 NECs. And this is very similar to what's already been approved in patients with small cell carcinoma of the lung. And we're also seeing cabozantinib in combinations with immunotherapy such as avelumab in patients in the second-line setting as well. Interestingly, we've also seen the results of the trial of FOLFIRI-bevacizumab versus FOLFIRI as second-line treatment in patients with poorly differentiated neuroendocrine carcinomas presented at ESMO this year, is showing you that bevacizumab provides no additional advantage, and therefore cementing the role of FOLFIRI as a second-line regimen in this sort of setting as well. So we've covered peptide receptor radionuclide therapy. We've covered the focus on new agents and grade 3 disease. One of the important questions we always have unanswered is what's the role of how do we better sequence our currently available agents in the treatment of neuroendocrine tumours? And there is the Sector trial coming from the Spanish neuroendocrine tumour group presented at ESMO this year, basically comparing everolimus versus streptozotocin 5-FU, then the reverse sequence in second-line setting, basically showing that in terms of the first PFS landmark, there was no difference between the two. It does appear that the chemotherapy regimen perhaps has slightly greater response rates. But again, unfortunately, the study was underpowered to come out with any firm conclusions. There are studies looking at the activity of cabozantinib temozolomide in lung and JEP-NETs after everolimus, sunitinib, or PRT. So we are seeing more and more of these sequential trials. But again, the data is lacking to guide us appropriately. So what is really missing in our research now in the treatment of patients with NETs? I think we really are often using the shotgun approach of treating all NETs, especially say all grade 1, grade 2 NETs as the same cohort, and similarly with the grade 3 NETs. But not all NET patients are the same. I mean, patients are extremely heterogeneous in terms of their tumour behaviour. And we often do see that when we do concurrent gallium-68 DOTA PET scans and FDG PET scans, which gives you a very different view of the distribution of well-differentiated and poor differentiated disease within the same patient and also within the same tumour deposits. So we need to better define the disease biology to help us to better select and individualise treatment. In other words, precision medicine in terms of what's being done with other malignancies. At the moment, we really do not have any validated proper biomarkers. There has been a lot of work on functional imaging, as I just stated before, circulating DNA, so increasing volume of research work. And we're currently doing a similar study in pancreatic nets at Peter MacCallum. There's also been work with circulating tumour cells. There's also been looking at genomics of neuroendocrine tumours, particular pancreatic nets, polydifferentiated neuroendocrine carcinomas and small bowel nets, and looking at targetable, druggable targets. And this has been in particular successful in pancreatic nets. There's also been a large volume of work of the NET test, which is a multi-analyte taken from blood, which may provide some predictive or prognostic role, but it's not widely available, and there are some question marks in terms of its proper utility. So we need better biomarkers to predict disease behaviour, and these need to be built in within all prospective research. We also need better studies to define the sequential therapy for all subclasses of neuroendocrine tumours. What is the best first-line therapy? As we're seeing, for example, PRT is coming on more and more into the first-line setting. What is the best second-line therapy? What is the best third-line therapy? And we also need to define what is the optimal combinations. And as you see from the current trials I described, we are seeing more and more biological agents combined with chemotherapy or combinations with immunotherapy. We're also seeing PRT combined with biological agents, chemotherapy, DNA damaging agents, or immunotherapy agents as well. So we're having a lot of phase 1, phase 2 activity, and it'll be very interesting to see eventually what is the phase 3 randomized trial activity. But we must always come back to the question, the trials should answer a very important question. They must be rationally designed rather than satisfying the regulatory agency requirements. And I think one example of that is the NETO2 trial, where patients with polydifferentiate with aggressive grade 3 neuroendocrine tumours are randomized to PRT versus high-dose SSAs, which really I think is an unethical study, and it doesn't really represent proper standard of care. But again, it meets regulatory authorities. So with all this trial activity, what's the best way of having patients involved in this process? And I think that when we're looking at clinical trial design, no matter what level we're looking at, we really should have the input of patients telling the clinicians what do they think is meaningful of value and what makes sense to them as patients with NETs. So we really need to have their input and opinion regarding the trial objectives and how meaningful they are to the patients. Whether it's, are we looking at optimal disease control or reduction in symptoms in terms of symptomatic trials, looking at quality of life, reduction and improvement. So patients themselves should be involved in the trial, some input into trial design, and also be involved in terms of the trial requirements and how burdensome these may be on patients in terms of time, in terms of investigations, in terms of the amount and duration of quality of life questionnaires, and really thinking and giving us input and saying, will these trials be of interest to patients? Will patients want to be recruited to these trials? And obviously they need to have input in terms of the consent forms as well. So really you need to have very well-trained consumer advocates to have relevant skills in providing such input. And it's up to the trial groups or patient advocacy groups such as NECA or such as INCA to have input in giving us access to these well-trained consumer advocates. And they need to be very well educated in terms of health literacy, especially in terms of the treatment of NETs. The patient impact may be less in phase 1 or first in human trials, but obviously it becomes much more important as you go to phase 2, phase 3 trials. And similarly when you're looking at patient preference or quality of life studies. So hopefully in this brief discussion, I hope it'll give you an idea of what am I excited about in terms of clinical trials in relation to neuroendocrine tumours, where I think the major gaps are, and how I think that patients need to be involved in trial design to answer good questions to produce good quality results and also to ensure that trial recruitment is completed, because neuroendocrine tumours are rare tumours. They are increasing in incidence. However, in clinical trials, we're often suffering the problem of poor recruitment or slow recruitment, and therefore closing trials, unfortunately, prematurely. Thank you.